When we talk about the models of care, what we mean is the way we think services should be organised for people with congenital heart disease. In our standards, we talk about 3 levels of care. Level 1 is the specialist surgical centres. This is where the really complex surgery and interventional cardiology takes place. The second level is about specialist cardiology centres. These can do all the specialist follow-ups and outpatient parts of care, but not the surgery or other interventions. Level 3 is local cardiology centres. This is the service in local general hospitals. Our standards apply to all 3 levels, but they make clear if something only applies at level 1, level 2 or level 3. The very first chapter of our standards is about the network approach, and it is no accident that we've put this first. The network approach tells you how all hospitals looking after people with CHD need to work together to make sure we get the best results for patients. A network is a group of services working together for adults and children across all 3 levels of service. When we talk to people about this, many of them who already work in a network told us what makes a good network. Everyone in the network needs to know what their job is and how they work with each other. There needs to be really good ways of sharing information so that when a patient moves from one part of the network to another, the information travels with them and everyone can access it and understand it. It needs to have all different parts of the heart service, not just heart surgery but also the monitoring and lifelong care of patients. So in light of what we have heard, what we are saying we should do is have networks right across the country, both local networks and broader, bigger networks that cover larger areas of the country. We want to make sure that if you need surgery, whether you're a child or an adult, it is only undertaken in specialist centres. We don't think that every hospital in the country, or even most hospitals in the country, should be doing this work. It is highly complex. The surgeons who perform it need to have special skills, and they need to be doing it very regularly. We also think that within the network, the different parts have to have a very clear understanding of how they work together and how they work with other services patients depend on, like intensive care, maternity, and so on. Not every network will look the same. It will depend on which part of the country you are in. For example, they will look different in a rural compared to an urban area. But whatever size and shape of the network, it is really important that the team of doctors and nurses get together regularly, we think weekly, to talk about the patients they are responsible for. We think that sharing of information is incredibly important and that within each network everyone should have access to the same information about their patient. Hospitals and doctors working together locally, across regions and nationally to get the best care. That is what networks are about. We want better results for patients and their families and consistent improvement right across the country. There is a section in our standards about staffing and skills which tells you what kind of mix of doctors, nurses and others you need to deliver a really good service and how you make sure you have the right numbers of each. We've been told that it's really important that within the CHD centres you have the right number of people with the right skills. Because this is quite a rare condition, it wouldn't make sense to have somebody doing this in every hospital in the country. Instead, it makes sense to concentrate people in a smaller number of hospitals. We've also been told that it's not just about the surgery or cardiology that takes place, it's also about taking care of how people feel. They need help to understand what is happening, so one of the skills people need is excellent communication skills. It is not just about being great at surgery, being great at listening and explaining is also very important. Part of our standards cover the number of surgeons and specialist staff who need to be in place to ensure the right service can be provided. This is not just 9 to 5, but 24 hours a day, 7 days a week, in case any emergency care is required. Our standards state what needs to be there to ensure 24-hour services throughout the year, and explain how we make sure that wherever you are in the country, you can see someone who can give you the care you need for the condition you've got. This will mean that we have the right number of staff with the right skills in each of the centres. That doesn't mean that every single centre will be able to perform every single procedure on every single patient, because sometimes particular specialist skills will be required which are only available in certain centres. If that happens, patients would either be transferred to another unit or a specialist would be asked to come and help. We think that the standards will mean that extra staff are needed in some centres. One of the chapters of our standards talks about interdependencies, the way different bits of service work together and the way some of them depend on each other. We need to be very careful when we are talking about a new service that we don't accidentally miss something which could have an effect on other services. We think that there are three main types of interdependency. The first is that congenital heart surgery for children has got a link to other specialist services for children which are not heart surgery. This is important because a lot of children, especially babies, have other problems as well as CHD, so they need care from other specialists too. The second kind of dependency is the same but for adults, so the links between specialist CHD surgery and other adult specialties. The third dependency is between congenital heart surgery for children and congenital heart surgery for adults. Very often it is the same surgeons performing the same kind of surgery on the same patients at different times in their lives. So we have three types of dependency. The standards spell out which services we think should be on the same site, which we call co-location, and which services could be somewhere else, as long as it can provide care patients need quickly enough. When we talked to people about this, they agreed with us that it was very important that CHD services work closely with other services, a number of which are not just for CHD. Good working relationships are very important, and the time it takes for a specialist doctor to see a CHD patient is a most important consideration. In some instances, a doctor needs to be there within 30 minutes. We had a lot of conversations about the importance of different services being on the same site, and different people had different opinions about this. Most people agree that the ideal would be to have everything together on the same site. Having said that, we understand that the way the health service is currently organised can make this difficult. For example, there are good reasons to set up children's hospitals because sometimes children require a place which is designed just for them. So this is a complicated issue. When we talked to people, they said it wasn't just about where services were, it was also about the way they work together in the patient's interest. So although there is no easy answer to this, taking into account all of the experts we've talked to, we decided that the right approach was to say that specialist heart care for children should be on the same site as other children's services. This is not because there is a simple answer, it's because the experts we spoke to throughout the process said to get the best possible service, that is what you would go for. This is also consistent with how the NHS provides other specialist children's services. Our standards also acknowledge that it would be great to have children's heart services and adult congenital heart services in the same place, but we know that not all of these services can be brought together, so what is really important is that we have good close working relationships between these two parts of the service. We believe that these standards will help ensure that wherever patients receive their care, all the experts they are likely to need are on site or available very quickly. As not all centres currently meet these requirements, they will need to consider how they can arrange their services in order to comply with these standards. We have a chapter in the standards about fetal diagnosis. That is spotting a problem before the baby is born, so that when the baby is born, everything possible is in place to make sure that both mum and baby get the best care available. The numbers at the moment tell us about 1 in 3 babies who could be picked up before birth or spotted before they are born. That is not a very good success rate, and we think we can do better. There are already some national requirements about how to detect heart problems in babies before they are born, but those standards have not yet been followed. So it is really important that whatever standards we introduce, we make sure that the training and understanding is in place and that there are ways of measuring how the quality is improving all the time. It seems from our conversations that one of the main issues is getting enough training for the people who perform the ultrasound scan. Doing the training once isn't enough, people need regular top-ups. Another key issue is about making the whole process quicker so that when mum has an ultrasound scan that shows there might be a problem, then very quickly further tests can be arranged, because it's very upsetting and very concerning if there's a long delay between the first test and any follow-up test. So we want our congenital heart disease networks to make sure that the standards are followed, that people get the right training, and that the service is organised in such a way that if someone does need a more specialist check, that can happen really quickly.